Your blood pressure is rising right now, not because you are stressed, not because you ate something salty an hour ago. It is rising because a system inside your body, one that has been adjusting itself every single second since the day you were born, has slowly started to shift its set point. And the most dangerous part is that you will not feel it happening. I am Dr. Warren Hung, and this is We Care Health. Today, I want to explain something that affects over 1 billion people on this planet, and that most of them will not know about until damage has already been done. I want to explain what is really going on inside your body when blood pressure goes up, not for a few minutes, not because of a bad day, but permanently. And I want to explain what it actually takes to reverse that process, and when reversal is still possible. But before any of that makes sense, we need to understand how the system is supposed to work when everything is functioning normally. Because if you do not understand the normal version first, you will never understand what breaks. So let us start there. Your blood pressure is not one thing. It is not a single force. It is the result of 3 systems working together, adjusting each other constantly, trying to keep a very specific balance. The first system is the heart itself. Your heart is a pump. That is its job. It contracts roughly 60 to 80 times per minute at rest, and each contraction pushes a wave of blood out into your arteries. The force of that wave hitting the artery walls, that is what we measure as the top number, the systolic pressure. The pressure that remains in between beats, when the heart is relaxed and refilling, that is the bottom number, the diastolic pressure. So, when someone tells you your blood pressure is 120/80, what they are really describing is the peak force and the resting force inside your arteries across one heartbeat cycle. But the heart does not decide your blood pressure alone. If it did, blood pressure would just depend on how hard and how fast the heart pumped, and that is not what happens. The second system is the arteries themselves. Your arteries are not stiff pipes. They are flexible, muscular tubes. They can widen and they can narrow. When the smooth muscle in an artery wall contracts, the tube gets narrower. When it relaxes, the tube opens up. This matters enormously. Think of it this way: if you pinch the end of a garden hose, the pressure inside goes up, even though the water flow has not changed. Your arteries work the same way. When they tighten, resistance goes up and blood pressure rises. When they relax, resistance drops and blood pressure falls. This is called peripheral vascular resistance. It is one of the most important numbers in blood pressure physiology, and most people have never heard of it. Now, the heart and the arteries together can adjust blood pressure moment to moment. When you stand up quickly, when you start running, when you get startled, your body changes heart rate and arterial tone within seconds. That is the short-term system. It is fast, reactive, and temporary. But there is a third system, and this one matters more than the other 2 when it comes to long-term blood pressure. This is the kidney. Your kidneys filter your blood, about 180 liters of it every single day. And one of the most important things they control is how much sodium and water your body holds onto versus how much it lets go of through urine. If your kidneys retain more sodium, water follows. More fluid in the system means more volume pushing against the artery walls. Pressure goes up. If your kidneys release more sodium, water follows it out. Volume drops. Pressure comes down. This is the long-term thermostat. The heart and arteries handle minute-to-minute adjustments. The kidneys handle the baseline, the level your blood pressure always returns to after the short-term fluctuations settle down. Arthur Guyton, a physiologist who spent decades studying this at the University of Mississippi, built an entire model of blood pressure regulation around this principle. His work, published through the 1970s and 1980s, showed that the kidney's handling of sodium and water is the dominant long-term controller of arterial pressure. His pressure natriuresis model remains one of the foundational frameworks in cardiovascular physiology to this day. So when everything is working correctly, you have a system that regulates itself beautifully. The heart pumps, the arteries adjust their width, the kidneys fine-tune the fluid volume, and blood pressure stays within a range that is safe for your organs, your brain, your heart, your eyes, your kidneys themselves. The problem is not that this system fails suddenly. The problem is that it fails slowly, so slowly that by the time you notice anything is wrong, the system has already been compensating for years. And that slow, invisible shift, that is exactly where the damage begins. Here is something that most people misunderstand about high blood pressure. They think of it as something that happens to you like catching a cold or breaking a bone. One day your blood pressure is normal, and the next day it is high. But that is not how it works, not even close. What actually happens is a slow drift, a gradual resetting of the system we just described. And that drift can take 10, 15, even 20 years before a doctor looks at a reading and says the word hypertension. By then, the process is not beginning. It has been running quietly for a very long time. So what changes first? Let us start with the arteries. Remember, your arteries are flexible, muscular tubes. They stretch when blood pushes through them and then recoil back. That stretch and recoil action is important. It helps smooth out the pressure wave from each heartbeat so that blood flows more evenly through your smaller vessels. But over time, the walls of those arteries begin to change. The smooth muscle cells in the artery wall start to thicken. The elastic fibers, the ones that allow the artery to stretch, begin to degrade and get replaced with stiffer collagen fibers. The inner lining of the artery, called the endothelium, starts to function less efficiently. It produces less nitric oxide, which is the molecule responsible for telling the smooth muscle to relax and open the vessel up. This process is called vascular remodeling, and it does not happen because of one bad meal or one stressful week. It happens because of years of exposure to slightly elevated pressures, slightly elevated inflammation, and metabolic signals that slowly push the artery wall toward a stiffer, less responsive state. Think about a rubber band. A new rubber band stretches easily and snaps back. But if you leave that rubber band stretched around a jar for 2 years, it loses its elasticity. It becomes stiff. It does not bounce back the way it once did. Your arteries go through a similar process, except it takes much longer, and you cannot see it or feel it while it is happening. Now here is the key point. When arteries become stiffer and narrower, peripheral vascular resistance goes up. And when resistance goes up, blood pressure goes up, even if the heart has not changed how hard it pumps. The same cardiac output, pushing against tighter tubes, creates higher pressure. This is basic physics, and it is one of the earliest measurable changes in the development of hypertension. But the arteries are only one part of the shift. Let us move to the kidneys. Under normal conditions, when blood pressure rises even slightly, the kidneys respond by excreting more sodium and water. This is the pressure-natriuresis relationship that Guyton described as pressure goes up, the kidney lets more fluid out to bring it back down. It is a self-correcting mechanism, and in a healthy system it works remarkably well. But in early hypertension, this curve shifts. The kidneys begin to require a higher pressure to excrete the same amount of sodium. In other words, the thermostat resets. Where your kidneys used to be comfortable maintaining balance at a systolic pressure of, say, 115, they now need 130 to do the same job, and then 140. And then higher. Why does this happen? There are several contributors. One is increased activity of the renin-angiotensin-aldosterone system, a hormonal cascade that tells the kidneys to hold on to sodium and water. This system is useful in acute situations, like dehydration or blood loss. But when it stays chronically activated at low levels, driven by things like excess body fat, chronic low-grade inflammation, or sustained sympathetic nervous system activity, the kidneys slowly shift their operating point upward. Data from the Framingham Heart Study, which has tracked cardiovascular health in thousands of participants since 1948, has shown that blood pressure tends to rise progressively with age in Western populations, and that this rise is closely associated with changes in arterial stiffness and kidney function over time. This is not a sudden event. It is a decades-long trajectory. And that brings us to the third shift, the nervous system. Your sympathetic nervous system is the branch of your autonomic nervous system responsible for the fight or flight response. It speeds up your heart rate, tightens your blood vessels, and tells your kidneys to retain sodium. In short bursts, this is useful and protective. If you are being chased by something dangerous, you want higher blood pressure temporarily. It keeps blood flowing to your muscles and brain. But the sympathetic nervous system was not designed to stay elevated all the time, and in modern life, it often does. Chronic psychological stress, poor sleep, visceral fat accumulation, these all contribute to a state of sustained sympathetic overdrive. The system that is supposed to spike and then settle back down begins to idle at a higher level. And that chronically elevated baseline has direct effects on all three components. It makes the heart beat faster and harder, it constricts the arteries, and it tells the kidneys to hold on to more fluid. Here is what makes this dangerous. None of these changes, arterial stiffening, kidney threshold shifting, sympathetic overdrive, produce symptoms. There is no pain. There is no shortness of breath. There is no warning sign on your skin or in your energy levels. Blood pressure can sit at 150/95 for years, and you will feel completely fine. Your body adapts to the new baseline. It recalibrates what it considers normal. This is why hypertension is called a silent condition. Not because it is harmless, it is one of the leading risk factors for stroke, heart attack, kidney failure, and vascular dementia worldwide, according to data from the World Health Organization. It is silent because the damage accumulates behind the scenes, in vessel walls and organ tissues, long before you or your doctor detect a problem during a routine check. And the longer these three shifts run unchecked, the more they begin to reinforce one another. Stiffer arteries raise pressure, which pushes the kidneys to reset their threshold, which retains more fluid, which raises pressure further, which accelerates arterial stiffening. The nervous system amplifies the whole cycle. That self-reinforcing loop, the way these three systems lock into each other, is what we need to understand next, because that is where the real cause of chronic high blood pressure lives. By now you understand the three players: the arteries, which control resistance, the kidneys, which control volume, and the sympathetic nervous system, which amplifies both. Each one of these systems can push blood pressure upward on its own, but that is not what makes hypertension so persistent and so difficult to undo. What makes it persistent is that these three systems do not operate independently. They talk to each other, they respond to each other, and once all three have shifted upward even modestly, they begin to lock into a cycle that sustains itself. That cycle is, in the clearest terms I can offer, the real cause of chronic high blood pressure. Let me walk you through how the lock happens. It often begins with a small, sustained increase in sympathetic nervous system activity. Maybe it comes from years of poor sleep. Maybe it comes from excess visceral fat, which is metabolically active tissue that sends inflammatory signals and stimulates sympathetic output. Maybe it comes from chronic psychological stress, not one bad month, but years of elevated baseline tension. The origin varies from person to person, but the downstream effect is consistent. The sympathetic nervous system begins to idle higher than it should. When sympathetic tone is chronically elevated, two things happen simultaneously. First, the arteries tighten. The smooth muscle in the vessel walls contracts more often and more firmly, raising peripheral resistance. Second, the kidneys receive a direct signal through renal sympathetic nerves to retain more sodium and water. So now you have two of the three systems already being pushed in the wrong direction by the same upstream signal. The result is a modest increase in blood pressure. Not dramatic, not alarming on a single reading. Perhaps your systolic pressure moves from 118 to 132 over the course of 3 or 4 years. Most people would not notice. Many doctors would note it but not act on it aggressively. And the body itself does not raise any alarms, because the change is slow enough that every tissue adjusts to the new level. But that modestly elevated pressure is now pressing against the artery walls with slightly more force. Every single heartbeat, every minute, every day. And over months and years, the arteries begin to respond structurally. The smooth muscle layer thickens, elastic fibers degrade, collagen deposits increase. The endothelium, the inner lining, produces less nitric oxide, so the arteries lose some of their ability to dilate on demand. This is the vascular remodeling process I described earlier, and it is not just a passive consequence of higher pressure. It actively makes things worse, because stiffer, thicker arteries mean higher resistance, which means higher pressure, even if nothing else changes. So now the arteries are not just being squeezed by sympathetic signals. They are structurally different. They are physically less capable of relaxing. And that structural change feeds back into the system as a permanent increase in resistance. Meanwhile, the kidneys are adapting too. Remember Guyton's pressure natriuresis curve, the relationship between blood pressure and how much sodium the kidneys excrete. In a healthy system, a small rise in pressure leads to a proportional increase in sodium excretion, which brings pressure back down. But when the kidneys are under chronic sympathetic stimulation, and when the renin-angiotensin-aldosterone system is mildly overactive, that curve shifts to the right. The kidneys now need a higher pressure to excrete the same amount of sodium. Their set point has moved. This is not a malfunction, in the way a broken bone is a malfunction. This is the kidney doing exactly what it is being told to do by the hormonal and neural signals it receives. The problem is that those signals are wrong, or more precisely, they are appropriate for a short-term emergency, but destructive when sustained over years. Now all three systems are locked in. The sympathetic nervous system is running too high, which tightens the arteries and tells the kidneys to retain fluid. The arteries are remodeling structurally, which raises resistance independently of nervous system input. The kidneys have shifted their pressure threshold upward, which means they are now defending a higher blood pressure as if it were normal. And the higher blood pressure itself feeds back into all three. It accelerates arterial stiffening, it changes kidney perfusion dynamics, and in some cases, it further stimulates sympathetic output through baroreceptor resetting. Baroreceptors are pressure sensors located in the walls of your carotid arteries and aortic arch. They detect how much the artery wall is stretching with each heartbeat, and they send signals to the brain to adjust heart rate and vascular tone accordingly. In a healthy system, if blood pressure rises, the baroreceptors detect the extra stretch and tell the brain to lower sympathetic output and increase parasympathetic activity, which brings pressure down. It is a braking system. But when blood pressure is elevated for a long time, weeks and months, not hours, the baroreceptors adapt. They reset to the new higher level. They begin to treat 140 systolic as the new normal. So instead of triggering a corrective response, they stay quiet. The braking system stops braking, and this allows the elevated sympathetic tone to continue unopposed. This is the loop. Sympathetic overdrive leads to arterial constriction and renal sodium retention. Arterial remodeling raises resistance structurally. The kidneys defend a higher set point. Baroreceptors reset and stop correcting, and each element reinforces the others. The Framingham Heart Study data showed clearly that individuals who developed hypertension did not jump from normal to high overnight. Their pressures drifted upward over years, often passing through what we now call pre-hypertension, or elevated blood pressure, a range where the loop is already forming but has not yet fully locked. The longer a person stays in that transitional range without intervention, the harder it becomes to bring the system back to its original set point. This is because the changes become increasingly structural rather than purely functional. A constricted artery can relax. A remodeled artery cannot simply unremodel on command. And this distinction between functional changes and structural changes is the single most important idea in understanding what can be reversed and what cannot. Because the title of this video promises reversal, and reversal is possible, but it depends entirely on where you are in this loop, how long it has been running, how much structural change has accumulated, and which interventions are applied to which part of the cycle. That is exactly what we need to talk about now, what reversal actually means in clinical terms, and what it takes to interrupt this loop before the window closes. Before I walk through what works, I need to be honest about the word reverse. It is a strong word, and in medicine, strong words need boundaries. When I say reverse, I do not mean cure. Hypertension is not a disease you eliminate like an infection. What I mean is this: it is possible, under the right conditions and at the right stage, to move the system back toward a lower operating point, to reduce arterial stiffness, to restore the kidney's sodium handling toward its original set point, to bring sympathetic nervous system activity down to a healthier baseline. In other words, to partially or fully undo the functional shifts that drive the loop if you reach them before they become permanent structural changes. That distinction matters. Functional changes are changes in how the system is behaving. The artery is constricted, but its wall is still structurally intact. The kidney is retaining sodium, but its tissue is not yet scarred. The sympathetic system is overactive, but the baroreceptors have not fully reset. These changes can be reversed. Because the hardware is still sound, it is the settings that are wrong. Structural changes are different. A remodeled artery with thickened smooth muscle and degraded elastic fibers cannot simply return to its original architecture. A kidney with early nephrosclerosis scarring of the tiny filtering units does not unscar. These changes are not fully reversible. They can be slowed. They can be prevented from getting worse. But they cannot be undone the way a functional shift can. So the earlier you intervene, the more reversible the process is. That is not a slogan. It is a physiological reality. Now, with that framing in place, let me walk through the interventions that have the strongest evidence for actually interrupting the loop. And I want to be specific about which part of the loop each one targets, because this is not a generic list of health tips. This is mechanism-targeted intervention. Sodium reduction. Targeting kidney pressure natriuresis. The most direct way to help the kidneys reset their pressure threshold is to reduce the sodium load they have to manage. This is not new advice, but the evidence behind it is more specific than most people realize. The InterSalt study, published in 1988, examined sodium intake and blood pressure across 52 populations in 32 countries involving over 10,000 participants. It found a consistent positive association between sodium intake and blood pressure levels across populations. Populations with very low sodium intake had almost no age-related rise in blood pressure, which tells us something important. The upward drift in blood pressure that Western societies treat as normal aging is not purely biological. It is, at least in part, driven by chronic sodium excess, overwhelming the kidney's ability to maintain a low set point. The DASH sodium trial, published in 2001 Inches, the New England Journal of Medicine, went further. It tested 3 levels of sodium intake, combined with either a typical American diet or the DASH diet, a diet rich in fruits, vegetables, whole grains, and low-fat dairy, and low in saturated fat. The results showed that reducing sodium intake from high to low levels reduced systolic blood pressure significantly, and the combination of the DASH diet with low sodium produced the largest reductions, comparable in magnitude, to some first-line antihypertensive drugs. What this means mechanistically is that sodium reduction gives the kidneys room to reset. When the sodium load drops, the kidneys do not need as high a pressure to excrete what is coming in. The pressure natriuresis curve begins to shift back toward the left, back toward normal. This works best when the kidneys are still functionally intact, before chronic damage has scarred the filtering units. Sustained aerobic exercise targeting arterial compliance and sympathetic tone. Exercise affects at least 2 parts of the loop simultaneously. First, regular aerobic exercise, the kind that elevates your heart rate for sustained periods, like brisk walking, cycling, or swimming, directly improves endothelial function. It increases the production and availability of nitric oxide in the artery lining, which allows blood vessels to dilate more effectively. Over weeks and months, this improved endothelial function helps reduce arterial stiffness and lower peripheral vascular resistance. Second, sustained aerobic exercise has been shown to reduce sympathetic nervous system activity. A meta-analysis published in the journal Hypertension in 2002, examining dozens of randomized controlled trials, found that regular aerobic exercise reduced systolic blood pressure by an average of approximately 4 to 5 millimeters Hg and diastolic by approximately 2 to 3 millimeters Hg in hypertensive individuals. Those numbers might sound small, but at a population level, even a 2 millimeters Hg reduction in systolic pressure is associated with meaningful reductions in stroke and coronary event risk, as shown in data reviewed by The Lancet. The mechanism here is not complicated. Exercise trains the cardiovascular system to operate more efficiently. The heart does not need to pump as hard. The arteries become more compliant. The nervous system learns to idle at a lower level. And all of those changes directly oppose the loop. But the key word is sustained. A single jog does not reverse anything. The evidence supports consistent, moderate-intensity aerobic activity. Most guidelines, including those from the American Heart Association, recommend at least 150 minutes per week, maintained over months and years. This is not a quick fix. It is a long-term recalibration. Weight reduction targeting sympathetic drive and hormonal signaling. Excess body fat, particularly visceral fat, the fat stored around your abdominal organs, is not passive tissue. It is metabolically active. It releases inflammatory cytokines. It contributes to insulin resistance. And critically, it drives sympathetic nervous system activation. This is one of the reasons why overweight and obesity are so strongly associated with hypertension across virtually every population studied. The Framingham Heart Study data demonstrated a clear, graded relationship between body mass index and blood pressure. For every unit increase in BMI, systolic blood pressure rose measurably. And the reverse was also. True weight loss was associated with meaningful blood pressure reduction, particularly when the weight lost was visceral fat. When visceral fat decreases, the inflammatory signaling drops, insulin sensitivity improves, and sympathetic nervous system activity falls. This directly reduces the upstream driver of the entire loop, the chronically elevated sympathetic tone that constricts arteries and tells kidneys to hold sodium. Clinical trials have consistently shown that a reduction of even 5 to 10% of body weight can produce significant reductions in blood pressure. Not in everyone, not uniformly, but consistently enough that weight management is considered a first-line, non-pharmacological intervention by every major cardiovascular guideline, including those published by the European Society of Cardiology and the American College of Cardiology. Potassium intake supporting renal sodium excretion. This one receives less public attention, but it is physiologically important. Potassium and sodium have a reciprocal relationship in the kidney. Higher potassium intake promotes sodium excretion. It essentially helps the kidney do its job more efficiently, clear more sodium at a lower pressure. The DASH diet's effectiveness was not only due to sodium reduction, it was also due to its high potassium content from fruits and vegetables. Data from the WHO and from large cohort analyses have supported the association between higher dietary potassium and lower blood pressure, particularly in individuals with high sodium intake. This does not mean potassium supplements are the answer. It means a dietary pattern that provides adequate potassium, mostly through whole, unprocessed plant foods, supports the kidney's ability to maintain a lower pressure set point. It works with sodium reduction, not as a replacement for it. Sleep quality and stress regulation targeting autonomic baseline. I mentioned earlier that the sympathetic nervous system is a central driver of the loop. Anything that keeps it chronically elevated contributes to hypertension, and two of the most common but under-recognized contributors are poor sleep and chronic stress. Sleep deprivation, even partial, over months, has been shown in controlled studies to increase sympathetic nervous system activity, raise cortisol levels, and impair endothelial function. A study published in Hypertension in 2006, using data from the cardia cohort, found that shorter sleep duration was independently associated with higher incidence of hypertension over a 5-year follow-up period, particularly in adults under 60. Chronic psychological stress operates through a similar pathway. Sustained activation of the hypothalamic pituitary adrenal axis and sympathetic nervous system keeps the body in a state of readiness that was designed to be temporary. When it becomes permanent, it contributes directly to the arterial constriction and renal sodium retention that feed the loop. Managing these does not mean meditating once or downloading a sleep app. It means genuinely restructuring sleep habits, consistent duration, consistent timing, reduced stimulant use in the afternoon and evening, and identifying sources of sustained stress that can be modified. These are not luxuries. From a blood pressure standpoint, they are interventions that target the autonomic nervous system as directly as any medication does. Now, I want to be very clear about something. All of these interventions work best when the changes driving hypertension are still mostly functional, when arteries have not yet remodeled extensively, when kidneys have not yet developed significant scarring, when the loop has been running for years, not decades. The window for full reversal is real, but it is not unlimited. And for many people, by the time blood pressure is detected and taken seriously, the loop has been running long enough that these interventions alone may not be sufficient. That is not a failure. That is biology. And it is exactly what we need to address next. There is a question that comes up often when people learn about the mechanisms behind high blood pressure. They hear about sodium, exercise, weight loss, sleep, and they ask, if I do all of that, can I come off medication? Or they ask the opposite. If I am already on medication, does that mean it is too late to change anything? Both of these questions come from the same misunderstanding. They treat lifestyle intervention and medication as two opposing choices, as if one means you are doing the right thing and the other means you have failed. That is not how it works. And understanding why requires going back to the loop. Remember, the loop has functional components and structural components. Functional changes like elevated sympathetic tone, arterial constriction, and shifted renal sodium handling are potentially reversible. That is what the interventions in the previous section target. But structural changes, arterial wall remodeling, loss of elastic fibers, early nephrosclerosis in the kidneys, baroreceptor resetting are far less reversible. They are physical alterations to tissue. You cannot exercise away a thickened artery wall any more than you can exercise away a scar on your skin. For someone whose blood pressure has been mildly elevated for a few years, and whose arteries and kidneys are still largely intact, aggressive lifestyle intervention may be enough to bring the system back to a safe operating point. The evidence supports this. Guidelines from the European Society of Cardiology and the American Heart Association both recommend a period of lifestyle modification as first-line treatment for stage 1 hypertension without organ damage, precisely because reversal is still plausible at that stage. But for someone whose blood pressure has been elevated for 10 or 15 years, perhaps undetected, perhaps undertreated, the situation is different. The arteries have remodeled. The kidneys may have early structural damage. The baroreceptors have reset. In that case, lifestyle changes will still help. They will still reduce sympathetic tone. They will still improve endothelial function to a degree. They will still lower the sodium load on the kidneys. But they may not be enough to bring blood pressure back to a safe level on their own, because part of the pressure elevation is now being maintained by structural changes that do not respond to behavioral intervention. This is where antihypertensive medication fits in. Not as a replacement for lifestyle change, not as a concession, as a rational, evidence-based response to the part of the loop that lifestyle alone cannot fully reach. Consider what the major classes of blood pressure medication actually do. ACE inhibitors and angiotensin receptor blockers reduce the activity of the renin-angiotensin-aldosterone system, the hormonal cascade that tells the kidneys to retain sodium and water. They directly target the kidney's shifted set point. Calcium channel blockers relax the smooth muscle in artery walls, reducing peripheral vascular resistance. They target the arterial component. Beta blockers reduce heart rate and lower sympathetic output. They target the nervous system component. Diuretics increase sodium and water excretion directly. They offload the kidneys. Each of these drug classes targets a specific part of the same loop we have been discussing. They are not blunt instruments. They are mechanistically precise tools aimed at the same systems that lifestyle interventions address. But they can reach the parts of the loop that have become structurally fixed and no longer respond adequately to behavioral changes alone. The ALLHAT trial, one of the largest antihypertensive treatment trials ever conducted with over 33,000 participants, confirmed that blood pressure reduction itself, regardless of which drug class achieved it, was the primary driver of reduced cardiovascular events. The SPRINT trial, published in 2015, further demonstrated that more intensive blood pressure lowering, targeting a systolic pressure below 120 rather than below 140, significantly reduced the risk of heart attack, stroke, heart failure, and cardiovascular death in high-risk patients. The clinical picture is clear. Lowering blood pressure reduces damage, period. And the method, whether lifestyle, medication, or both, matters less than the result. For most people with established hypertension, the honest answer is that they will benefit from both. Lifestyle changes address the functional components and slow further structural progression. Medication manages the structural components that lifestyle cannot reverse. Together, they cover more of the loop than either one alone. This is not a moral judgment. This is physiology. The body does not care whether your blood pressure came down because you ate less sodium or because you took an ACE inhibitor. Your artery walls do not know the difference. Your kidneys do not know the difference. What matters is that the pressure came down and the damage slowed. So here is the takeaway from everything we have discussed today. High blood pressure is not a mystery. It is not random. It is not simply genetic bad luck. It is the result of three interconnected systems: arteries, kidneys, and the sympathetic nervous system gradually shifting their operating points upward and locking into a self-reinforcing cycle. That cycle runs silently, often for years, before it is detected. And the longer it runs, the more the changes move from reversible to structural. The process can be interrupted. It can, in many cases, be partially or fully reversed if you reach it early enough and if you target the right parts of the loop with the right interventions. Sodium reduction helps the kidneys. Exercise helps the arteries and the nervous system. Weight loss reduces the upstream sympathetic drive. Sleep and stress management lower the autonomic baseline. These are not wellness trends. They are mechanism-targeted strategies with strong clinical evidence behind them. And if the process has gone far enough that structural changes have taken hold, medication is not a defeat. It is the appropriate tool for the part of the problem that behavior cannot fix. The goal is the same either way: bring the pressure down, protect the organs, and slow the loop. If you found this useful, consider subscribing to We Care Health. I am Dr. Warren Hung. Take care of yourself and take your blood pressure seriously, especially when you feel fine. That is exactly when it matters most.